So good evening, everyone. Greetings to all of you from Mahajan Imaging. Let us start with today's talk on the role of nuclear medicine in clinical nephrology. So talking about nuclear medicine, it has a crucial role in the functional assessment of the urinary tract. And this is despite the recent technical advances in the CT, MRI, and ultrasonography machines. Because the nuclear medicine techniques maintain the gold standard status in the diagnosis of upper urinary tract obstruction, in which we do the diuretic renography, and pyelonephritic scarring secondary to urinary tract infection, in which we do the cortical scintigraphy. Basic indications include evaluation of renal perfusion and function, obstruction, in which we do the Lasix renal scan, renovascular hypertension, in which we do the captopril renal scan, infection imaging, in which we do the renal morphology scan, pre-surgical quantitation, in which it is required before nephrectomy, renal transplant evaluation, and congenital anomalies or masses, in which we do the radiology scan. Talking about the renal radiopharmaceuticals, we have a lot of radiopharmaceuticals, but we need to address the basic clinical question. So we have to choose the renal radiotracers accordingly. For example, if we need to look at the renal perfusion, then the agents of choice will be MAC3 or EC or DTPA or GHA. If we want to see the morphology, then DMSA or GHA remain the agents of choice. To look at renal obstruction, MAC3, EC, DTPA, or OIH are used. For relative function, all the renal radiotracers can be used. For GFR quantitation, we can use IO125 iothalamate or chromium 51 EDTA or DTPA. And for ERPF quantification, we use MAC3, OIH, or EC. This is basically what a DTPA normal scan looks like. We can see the perfusion in the abdominal aorta, and we can see the tracer in both the renal areas. And then we look at an abnormal scan. We will first see the normal, the renal perfusion, cortical uptake, and drainage. So we can see good perfusion, good cortical tracer uptake, and good drainage in both the kidneys. And then we look at a case of renal artery occlusion, in which we see good tracer accumulation on the left-hand side, but there is absent tracer accumulation on the right-hand side. This is a typical case of right renal infarct, in which the perfusion, cortical uptake, and drainage, all phases are impaired. So when we talk about a renovascular study, we make a time activity curve in the form of a renogram, which has three phases. One is the count rate, and one is the phase in which the count rate increases, that is a vascular phase. Then the uptake peaks, and this is the parenchymal phase. And third is the excretory phase, in which we see the drainage pattern. So first of all, let us talk about the evaluation of a hydronephrotic kidney. We do the diuretic or the Lasix renal scan. The basic principle remains that in hydronephrosis, there is tracer pooling in the dilated renal pelvis, and Lasix induces increased urine flow. If the system is obstructed, it will not wash out, and if it is dilated but non-obstructed, it will wash out after Lasix. We can quantify the rate of washout in the form of T-half. The basic indications are to evaluate functional significance of hydronephrosis, to determine the need for surgery, because in an obstructive hydronephrosis kidney, surgical treatment remains the modality of treatment of choice. And in a non-obstructive hydronephrosis, medical management can help the patient. And we also need to monitor the effect of therapy. Lasix is a loop diuretic. It washes the radiopharmaceutical out of the distal nephron, calyces, and pelvis. It is secreted by the proximal tubule and reaches its site of action in the tubular lumen of the thick ascending loop of Henle via the tubular fluid. The response usually begins 2 to 4 minutes after the injection, but the maximum diuresis is usually reached 15 to 18 minutes after injection of the tracer. The dose remains 1 mg per kg in infants, 0.5 mg per kg in children in the age group of 1 to 16 years, and 40 mg in adults. Now, the timing of Lasix administration is not universally standardized in renography, and we have 3 different approaches, like it can be F plus 20, in which the Lasix is injected 20 minutes after the injection of tracer, F minus 15 when it is injected 15 minutes prior to the tracer, or F0 when it is injected at the beginning of the study along with the radiopharmaceutical. And then when we look at the time activity curve or the renogram curve, this is what a normal renogram curve looks like, the type 1 curve, in which we see a good peak and good drainage pattern. The second, the type 2 pattern, is the obstructed, in which there is good tracer uptake, but the drainage is impaired. And even after Lasix, the drainage is not there. And then we have a type 3A, in which we call a hypotonic curve, in which there is drainage as soon as we give Lasix. The curve comes down. And then we have an equivocal type 3B, in which after administration of the diuretic, the curve drains very slowly. Then there is another type 4 type curve, which is a delayed compensation, in which the curve comes down after diuretic but rises again. Talking about the quantitative parameters derived from a renal scintigraphy, renogram, differential function, Tmax, T-half, transit times, 20 by max or 20/3 ratio, and GFR are the quantitative parameters which help a nuclear medicine physician in making a report. The interpretation depends on not only the T-half alone, but we interpret the whole study, the dynamic images, the washout curve shape, whether it is concave or convex, and then the T-half values. But then there are different limitations and pitfalls in performing and assessing the diuretic renography. Most important is the hydration status of the patient, and then renal function insufficiency, also bladder empty. Talking about the acquisition parameters in which the patient position or movements affect the study, or the choice of radiopharmaceutical, the timing of Lasix administration, and the change of position or post-void or late images are a limitation in which we can have different results, and it can hamper the quality of reporting. Then the way a nuclear medicine physician processes the images, draws the region of interest, draws the background, they all affect the quality of reporting. Also, the parenchymal aspect and the renal function of the patient per se, the response to Lasix, and the level of urinary drainage impairment, they all affect the quality of report. Talking about a study, this is what a normal study looks like. Initial phases, we see the perfusion. Then we see the perfusion time activity curve. And in the next phase, we see the cortical uptake. We see cortical uptake in both the kidneys simultaneously. And slowly we can see the drainage pattern. And when we draw the time activity renogram curve, we can see good tracer uptake, good perfusion, and then good drainage. This is what a normal curve looks like. Talking about a grossly hydronephrotic right kidney with right-sided PUJ obstruction, first we look at the normal side. The left kidney is absolutely normally perfused, cortical uptake is normal, drainage is normal. But look at the right side, grossly dilated hydronephrotic right side with tracer accumulation even till 4 and 24 hours. So this is a PUJ obstruction on the right side. This is what the curve looks like. We can see normal renogram curve on the left side and the rising curve on the right side. And this is another case of an obstructed system on the right side. Second case in which the system is dilated, but this is not obstructed, in which we see left side normal perfusion, normal cortical uptake, normal drainage, but the right side is grossly dilated, but it is not obstructed. The tracer washes on its own. By the end of the study, there is hardly any tracer left. And this is what we call an equivocal study. We see that the tracer drains only partially after Lasix administration on the left side. The right side is absolutely normal. This is what we call a double rising curve. On both the sides, the curve comes down after Lasix intervention, but again rises. This is a case showing follow-up after surgery. The initial images are the pre-surgery pictures, and the second set of pictures are after the surgery, and we can see there is significant improvement in the cortical function and the drainage pattern on the right side. Talking about the evaluation of neonatal hydronephrosis, how to proceed with a child who presents with neonatal hydronephrosis. We need to do an ultrasound before discharge from the hospital in case he or she has severe grade hydronephrosis, or a solitary kidney with any grade of hydronephrosis, or bilateral hydronephrosis. In other grades, ultrasound is required in the first month of life. In cases of persistent moderate to severe hydronephrosis, DRCG or VCUG and functional imaging are the modality of choice. And decision is based on a case-by-case basis in mild hydronephrosis. In postnatal evaluation, ultrasound is very easy. It is repeatable, very cheap and quick. It gives us quick results. We can see the bladder wall thickness, we can see the lower ureters, and we can see the ureterocele duplicates. In neonatal patients, considering the immaturity of nephrons in newborns, the usual recommendation is that the diuretic renography be delayed until the age of 4 weeks. Before that age, renal tubules may be unable to respond to the effect of Lasix. Renal function matures gradually during the first 2 years of life. So GFR also rises only slowly from 40 ml per minute at 1 week to 120 ml per minute at 2 years. So talking about patient preparation in case of neonates children, it is the parents who have to be told to offer the child that the child drinks liberally before getting the test done in the department, especially in hot weather. And the child has to be adequately hydrated. And usually oral hydration is sufficient in the form of water or juice or milk. And IV hydration is not necessary. Bladder catheterization is also not always necessary. It is necessary in rapidly filling bladder or a bladder with poor compliance in hydroureter, VUR, neuropathic bladder, small capacity bladder, dysfunctional bladder, or posterior urethral valves. So ultrasound and diuretic renal scintigraphy are the modality of choice in the treatment of these babies. If the relative function is more than 40%, these children are kept on follow-up. If the function is less than 40% and washout with diuretic is more than 50%, again, the child has to be on follow-up. If the washout is 12 to 50%, we have to repeat the diuretic renal scan within 3 months. If the washout is 5 to 12%, we need to repeat the scan within 1 to 2 months. And if the washout is less than 5%, the child will require immediate surgery. So operative intervention is only required if there is a fall in relative function and washout and it deteriorates considerably. So the basic approach is ultrasound at the end of first week, EC or MAC3 renography at 4 to 6 weeks, MCUG if the RPD is more than 10 mm, or if DMSA is abnormal. DMSA is required if reflux is confirmed, and then if the babies are put on prophylactic antibiotics So only fewer than 20% will require surgery. Talking about the evaluation of renal infections in UTIs. So UTIs occur in 3 to 5% of girls and 1% of boys. In boys, most UTIs occur during the first year of life, and in girls, it occurs by the age of 5 years, with peaks during infancy and toilet training, and 80% of these are by E. coli. And then there are various risk factors for UTIs, and VUR is a very important risk factor for pyelonephritis, but not all patients with pyelonephritis have VUR. So we must remember that pyelonephritis may lead to renal scarring and then end-stage renal disease, hypertension. So early diagnosis and treatment becomes very critical. Clinical and lab diagnosis of renal involvement in UTI is unreliable. So who needs imaging? Who is a child at risk? The child who will show clinical signs. I am talking about not only the children, adults also, with clinical signs. Example, poor urinary stream or palpable kidneys, atypical organism, high fever, septicemia, or failure to respond to antibiotic treatment within the first 48 hours, or recurrent UTIs. And who does not need imaging? Vast majority of children with UTIs are not at risk of subsequent complications. So indiscriminate use of imaging in every child with the first diagnosed UTI is unlikely to be effective. And how can imaging be used? It can be used to localize the infection, to detect anatomical abnormalities, to detect VUR, to show renal scarring, and to study bladder function. So in childhood, ultrasound is the first choice, followed by DMSA or a GHS scan, DRCG, and more renograms and less IVPs. Talking about the radionuclide cystograms, the basic indications are in the evaluation of children with recurrent UTIs, 30 to 50% have VUR. Then follow up after initial VCUG, assess the effect of therapy or surgery, and also for screening of siblings of reflux patients. So VUR can be performed in two methods. One is the indirect radionuclide cystourethropy, which is done by the DTPA study. It is non-invasive but less sensitive. And the most sensitive is the DRCG, in which we do the suprapubic injection into the full bladder. It is invasive but very, very sensitive. So this is what a normal DRCG scan looks like. So after suprapubic injection, we can see the tracer instilled into the bladder, and the child sits on the seat, and during the filling and the voiding phase, the images are required in dynamic mode. During the voiding, we can see there is no reflux of the tracer in bilateral ureters. Then we acquire the post-void image also. And this is another child showing VUR, in which we can see the reflux of tracer from the bladder to the left ureter. So we can see there is significant tracer reflux on the left side, and the tracer is reaching up to the renal pelvis. So this is the voiding phase and then the post-void phase. This is what a scan looks like for a reflux nephropathy. We can see the right side, the kidney is absolutely normal in contour, homogeneous tracer uptake, and there are no perfusion defects. And on the left side, there are multiple wedge-shaped defects. We can see cortical scarring, multiple cortical scarring on the left side. We can also calculate the residual volume, the post-void residual volume based on the counts. This is another child showing right-sided VUR. We can see the tracer in the bladder refluxing into the right side ureter. And this is a patient showing bilateral VUR. We can see reflux of tracer in bilateral ureters up to the renal pelvis bilaterally. So the advantages and disadvantages of direct and indirect cystography. The advantages of MCUR, we can see the morphology also. we can do grading, and we can do the study in any age. But it has a very high radiation burden, and these snapshots give a radiation burden to the gonads. And also the sensitivity is low. And the patient has, it's a very invasive technique in which bladder catheter is required. For direct radionuclide cystography, it is highly sensitive, and we can see the filling and the voiding stages, and we can see this at any age. It carries a very low radiation burden, but again, we may require bladder catheter, and then we do not do any grading on the basis of morphological data. In indirect radionuclide scintigraphy, it is non-invasive. It gives a low radiation burden, and we get information, but we also get information about the renal function in the form of a DTPA scan. But then, due to partial bladder filling, it has a low sensitivity, and it is only advantageous in patients older than 3 years of age. So this is how we can actually grade the reflex severity in a radionuclide cystography. We can grade these as grade 1 when the tracer reaches up to the medullator, grade 2 when it reaches the pelvis, and grade 3 when we can see tracer in the renal pelvis and the kidney. So mild, moderate, severe, radiologically, which is 1 is what we call in nuclear medicine as mild. Radiologically 2 and 3 we call as mild to moderate. Radiologically 4 to 5 we call it as severe. Another case in which we can see significant reflux even before the pre-void. Talking about the indications of renal cortical scintigraphy, we can determine the involvement of the upper tract in acute UTIs, detect cortical scarring in chronic pyelonephritis. We can do follow-up imaging in post-transplant cases. We can do imaging in polycystic or multicystic kidneys, and also in renal agenesis, ectopia, fusion, or horseshoe kidneys. And in acute pyelonephritis, we see single or multiple cold defects, photopenic defects, but the renal contour is not distorted. We see diffusely decreased uptake. We can see a diffusely enlarged kidney or focal bulging. But in chronic pyelonephritis, we see a volume loss, cortical thinning, and we see defects which are typically wedge-shaped defects with sharp edges. So the differentiation of acute pyelonephritis versus chronic pyelonephritis can become unreliable. And renal cortical scintigraphy as a cold defect can also be seen as in both acute or chronic pyelonephritis, also in hydronephrosis, cysts, tumors, traumas, or infarcts. So this is what a normal DMSA scan looks like. We can see good tracer uptake, cortical contour, the size, shape is maintained. The normal DMSA scan. And this is a case of acute pyelonephritis in which we can see the cortical contour is maintained. There is no volume loss, but there is a photon deficient area at the upper pole of the right kidney. Again, a case of pyelonephritis in which we can see multiple photopenic cold defects. Another case of right-sided pyelonephritis, we can see cold defects on the upper pole of the right kidney. And then this is how this patient has progressed. In the initial phases, we can see cold defects, which are small in size, and in 6 to 8 months later, this kidney has deteriorated. And after 18 months, we can see significant reduction in the perfusion, the cortical uptake, and there are multiple defects in the kidney because this was an uncorrected VUR and the kidney progressively deteriorated. This is another case of a scarred kidney. The contralateral kidney is showing absolutely normal contour, good uptake, and look at the scarred kidney. And this is a case of bilaterally poorly functioning kidneys. The entire tracer we can see in the background, but both the kidneys are showing such poor uptake that we can see multiple defects in both the kidneys. So DMSA scintigraphy is more sensitive than IVU, ultrasound, and even color Doppler in the detection of both acute lesions and late sequelae. Scintigraphic abnormalities in case of acute UTIs, regional defects can be attributable to acute infections, but also to any other underlying disease like renal abscess, hydronephrosis, cysts, or duplicate kidney with abnormal upper or lower moiety. So a DMSA scan can be performed during an episode of suspected acute pyelonephritis, and this can be treated as a gold standard to localize the site of infection. In congenital anomalies, we can see agenesis, we can see ectopia, fusion like in horseshoe, across fused ectopia, we can see polycystic kidneys, multicystic dysplastic kidneys, or pseudomasses. This is a case of a horseshoe kidney. We can very well see how both the lower poles of both the kidneys are medially displaced, and then there is a connecting parenchymal tissue in between. Another case of a horseshoe kidney, so very well differentiated on a DMSA scan. And this is a case of left agenesis on a DMSA scan. This is a case of crossed renal ectopia on a GHA scan. Another case of crossed renal ectopia. And then we also did a DMSA SPECT. This is a low-lying right-sided kidney on a DMSA scan. We can see another case in which there is this is a multicystic kidney, and we can see such a grossly enlarged and photopenic defect in the kidney. Now talking about the GFR estimation. So for GFR, inulin is the ideal method of calculating GFR, and chromium label 2 EDTA is considered the gold standard. But nuclear techniques in steady state require, and also in patients in which no blood sampling can be done, or we want the results quickly and in single bolus techniques, we can do DTPS scans and give you the results using Gates formula. The advantages are that the measurement of injected activity is very easy and precise, and the counting efficiency is very high. It is very cheap, and the GFR calculated with DTPA is just 5% underestimated due to the protein binding. Talking about ERPF or plasma clearance, it is a measure of the volume of plasma which is completely cleared of the substance each minute in the urine by tubular secretion. So for these, the tracers that we normally use are technetium labeled to MAG3 and EC. The tubular secretion of the PAH is 10% or less, so the term effective is used. Talking about evaluation of renovascular hypertension, we do a captopril renal scan, and this is used in the cases of renal artery stenosis or ischemic nephropathy, in renovascular hypertension, and this is potentially curable by renal revascularization. We all know this is a renin-angiotensin system, and the captopril, it acts at this level. So we can very well see the effect of captopril in case there is a hemodynamically significant renal artery stenosis. The prevalence is less than 1% of the unselected population with hypertension, and the clinical features are abrupt onset hypertension in child or adult less than 30 years, and severe hypertension which is resistant to medical treatment, and unexplained or post-ACE inhibitor impairment in renal function, hypertension with abdominal bruits. If these are present, there is a moderate risk of renovascular hypertension. The gold standard remains an angiography, but the initial non-invasive tests include the ACE inhibitor renography and a duplex sonography. Other tests are MRA or a captopril test and the renal vein renin levels. ACE inhibitor renography processing is done in the same way in which we do the GFR estimation. We see relative uptake and the split renal functions. If there is a fall of more than 10% after administration of captopril, or if the time to peak is a delay of 2 to 3 minutes, or 20-minute to peak ratio, there's a rise of more than 1.5, or there is a prolongation of parenchymal transit time. This favors high probability of there being hemodynamically significant renovascular hypertension. So this is what a positive captopril scintigraphy looks like. We can see a baseline study, and then after administration of captopril, we can see there is significant fall in GFR on the left side. The choice of ACE inhibitor these days now is enalapril, in which 0.04 to 0.05 mg per kg dose is administered to the maximum dose of 2.5 mg. It is given IV over a period of 3 to 5 minutes, and the radiopharmaceutical has to be administered 15 minutes later. Talking about evaluation of renal transplants, this is what a normal renal transplant looks like. We can see normal renal perfusion, normal renal cortical uptake, and good tracer drainage in this transplant. And this is a case of allograft rejection. We can see inhomogeneous tracer uptake in the perfusion phase, also in the cortical tracer uptake phase, and also in the drainage pattern. This is the case of allograft rejection. So we can see decreased perfusion and patchy blood pool uptake and prolonged parenchymal transit. There is worsening of perfusion and uptake from one study to the other over a period of 2 to 3 days. And there is a fall in one full grade of the renogram coincident with rejection. Hyperacute rejection is also seen on a renal scan, in which we can see that the kidney fails to be normally perfused, sometimes can be delayed from minutes to hours, and the radionuclide examination shows a photopenic area at the graft location. So we can see hardly any perfusion, cortical uptake, and no drainage also. So this is a case of ATN in which there is a vasomotor nephropathy, and the scintigraphic findings include the perfusion is preserved. We can see good perfusion in the initial phases, but there is impaired uptake of tracer and diminished excretion, which is documented by the delayed Tmax, T-half, and a high 20/3 minute ratio. This is a case of post-transplant urinary leak. We can see there is radioactive concentration around the transplant. Talking about testicular scintigraphy. So this is a normal dynamic study, and this is a normal static image. We can see normal perfusion in bilateral testicles. And then this is a case of acute testicular torsion. We can see a photopenic defect. And then in the workup for renal transplant and follow-up in patients with CRF. So nuclear imaging plays a critical role in which we can do evaluation of the cardiovascular system also, because most of these patients of CRF, they have compromised cardiovascular system also. So we can do a MOGA study in which we study various functional cardiac parameters, including the LVEF, which may be of value in case we are thinking about workup for a renal transplant eligibility, and also in cardiac functional follow-up in cases of CRF. We also do myocardial perfusion imaging in these patients because this is useful in renal transplant workup and follow-up. And also in diagnosis of coronary artery disease, location and severity, assessment of the impact of coronary stenosis on renal perfusion. It helps to distinguish viable ischemic myocardium from scar assessment and stratification for major adverse cardiac events and sudden cardiac deaths following myocardial infarction, and preoperatively for major surgery in patients at risk for coronary events. It is also used to monitor treatment effects, that is after revascularization, medical therapy, and lifestyle modifications. Then we also do cardiac PET, in which we do myocardial viability imaging, which is helpful in differentiating between infarcted and hibernating myocardium. We can prognosticate improvement in LVEF and symptoms prior to reperfusion, and we can do sympathetic imaging also. We can quantify the functional severity of myocardial injury and remodeling associated with ischemic and non-ischemic cardiomyopathy, judging the likely response to medical and device therapy for heart failure, identifying the substrate that places the patient at highest risk for arrhythmic sudden cardiac deaths, identifying the arrhythmic focus prior to any electrophysiological ablation. Talking about endocrine system, we also do hyperparathyroidism imaging, and we assess there is a presence of parathyroid adenoma or hyperparathyroidism in proven hypercalcemia and raised PTH. And we also, this allows for an intraoperative localization using a gamma probe also, which is less invasive, but then we can guide the clinician accordingly. In GI system, we can do occult bleeding studies, which is particularly beneficial in hyperuremia associated bleeding. And we also do gastric transit studies, which may be beneficial in case patient has CRF and poorly controlled diabetes mellitus. We also do infection imaging, in which we can localize the site of infection in patients of PUO or acute allograft rejections, or assessing the response to antibiotic therapy. Talking about musculoskeletal system, we can do imaging of the primary tumor in biochemically suspected bone tumors, example raised ALPs, or assessment of primary bone tumors detected radiologically, example sclerosis, survey for metastasis typically inducing increased osteoblastic activity, example renal malignancies, skeletal survey and staging for other bony pathologies, detection and staging of AVN, especially in patients of chronic corticosteroid immune suppression. We also do VQ scans in case of suspected acute pulmonary thromboembolism in patients at risk, especially those with contraindications to CTPA or where the risk of CTPA outweighs the benefit. In case the patient has iodine allergy or renal failure patients, any pre-menopausal females, or screening for acute pulmonary thromboembolism when radiation exposure from CTPA is deemed inappropriate according to the risk-benefit ratio. So lastly, this is the beautiful place from where I come. So this is located in the subsurging development area. And briefly telling you, this is located right next to the IIT flyover. And whenever you get a chance, do visit, in which there's a basement in which we have 3 MRI scanners plus CT scanners in the basement, and in the ground area, we have the waiting area and parking. The first floor is dedicated to the nuclear imaging, molecular imaging, and digital PET CT. The second floor, we have the ultrasonographies, X-rays, CBCT, and DEXA machines. Third floor, we have the AI and genomics research and the path labs. And the fourth floor, we have the conference room and the training rooms. Thank you so much for your patient listening. Thank you very much for giving me this opportunity to speak to your DNB students. Thank you so much, Dr. Kher and your team.
Thank you very much, ma'am. Can we have some questions from the students, ma'am?
Yeah, sure.
So the audience, if you have some questions, kindly put in the chat box or unmute yourselves. No questions, it seems, ma'am. And we can share this presentation with the students, ma'am?
Yeah, sure.
With the recording and all. Thank you so much, ma'am.
Yeah. Pleasure.
And if there are no questions, then we can thank ma'am.
Thank you.
Thank you, ma'am, so much for your sparing your time, ma'am.
Thank you.
Ma'am.
Thank
you.
you, everyone.